Hi guys, welcome to our channel Inspiring Minds. So today we are here with a very interesting topic, that is auditory pathway and brainstem evoked response audiometry. So now let's discuss about auditory pathway. We are going to discuss about auditory pathway. Okay. So what happens? First, the sound is picked up by the pinna, and from the pinna it goes to the external auditory canal, and from the external auditory canal it will vibrate the tympanic membrane, and tympanic membrane will set the ear ossicle into vibration. Now the stapes footplate will move the perilymph. The stapes footplate will move the perilymph present in the scala vestibuli. Now this moved perilymph will go from the helicoderma to scala tympani. It will go to scala tympani. Once this movement travels in the scala tympani, this will lead to the vibration of the basilar membrane. And now when the basilar membrane moves, on the basilar membrane are present the hair cells. Now this hair cell will undergo distortion, and there will be opening of the potassium channel. That will lead to the development of the electric impulse. That will lead to the generation of electric impulse. So this impulse travel in the cochlear nerve if the summating potential is sufficient to develop the action potential. Okay, so this will develop stimulation of the cochlear nerve. Now from the cochlear nerve starts our auditory pathway. So what is the very famous mnemonic to remember auditory pathway? Let's discuss about that mnemonic. So what is the mnemonic? E coli ma. E. coli ma. So remember this mnemonic, E. coli ma. Okay, you know organism E. coli and ma. E. coli ma. Okay. From E I mean eighth nerve. From E I mean eighth nerve. From C I mean cochlear nucleus. From O I mean opposite and olivary nucleus. From L I mean lateral lemniscus. From L I also mean largest. From I mean inferior colliculus, and from M I mean medial geniculate body. From A I mean auditory cortex. Okay, so let's discuss about this mnemonic. Okay, so in the diagram you can see that first there will be stimulation of the eighth nerve. Now this eighth nerve will reach the ipsilateral side of the cochlear nucleus. And from the cochlear nucleus, majority of the fiber will move on the opposite side. With the help of trapezoid body. They will move on the opposite side with the help of trapezoid body, and on the opposite side they will relay into the superior olivary nucleus. So very simple to remember. From O, olivary nucleus, and opposite. So opposite side of olivary nucleus. When I used the term mainly, you must remember this point. I used the term mainly. I not used the term only. So this means that some of the fiber also travel in the ipsilateral direction. So this was important, that mainly the fiber crosses in the opposite direction through the trapezoid body, reaches the superior olivary nucleus, relays there, and from there arises new order neuron, and that is known as lateral lemniscus. Now this lateral lemniscus will relay in the inferior colliculus. Okay, from inferior colliculus, the nerve fiber will reach the medial geniculate body, and from the medial geniculate body, nerves will reach the auditory cortex. So where does this auditory cortex is present? So consider this is your temporal lobe. Temporal lobe is divided into 3 gyri with the help of 2 sulci. So the superior gyri in its posterior portion has Brodmann area number 41, and this Brodmann area number 41 is your auditory cortex. So auditory cortex is present in the posterior part of superior temporal gyrus. And what is the Brodmann area number? Brodmann area number for auditory cortex is 41. You must remember this point. Okay, so in the auditory pathway, we have discussed it in a very simple manner. First, it will stimulate the cochlea. From the cochlea arises 8th nerve. 8th nerve will reach the cochlear nucleus. From cochlear nucleus, mainly the nerve fiber crosses to the opposite direction with the help of trapezoid body. On the opposite direction, it relays in the superior olivary nucleus. From the superior olivary nucleus, the nerves will travel in the form of lateral lemniscus, and from lateral lemniscus, it will reach the inferior colliculus, and from inferior colliculus to medial geniculate body, and from medial geniculate body to the auditory cortex present in the posterior part of superior temporal gyrus, and its Brodmann area number is 41. So this is about the auditory pathway. One more very important thing you can see in this diagram is at various levels in the auditory pathway, there is interconnections between the auditory pathway. This help us in binaural hearing, that is hearing from both the ears. Okay, so perception of sound is better, and we can also get the direction from which the sound is coming. Okay, so this is all about the auditory pathway. Now, one of the very important concepts regarding auditory pathway is BERA. So what is BERA? First, write the full form. Brainstem Evoked Response Audiometry. So this is your BERA. Okay, this is your BERA. Now, what happens in BERA? In this diagram, you can see that there are various synapses. So when the electrical impulses are traveling in the synapses, some amount of the energy will be lost. In BERA, we pick these energies. In the form of various waves. So what are the various waves and how many waves are present? First, how many waves are present? In a normal individual, 5 to 7 waves are present. Okay, 5 to 7 waves are present. If one word answer is asked, you can go for 7 waves. 7 waves are present, but mostly 6th and 7th wave are not important for us. So we can remember that there are 5 to 7 waves. If one word answer is asked, we can go for 7 waves. So from which electrical stimulus these waves are formed? This is important for us. So let's discuss. This we can remember with the same mnemonic, that is E. coli, but here we have to increase one E. So we remember it as double E. coli. Okay, so let's see. By first E, I mean distal portion of 8th nerve. By this E, I mean proximal portion of 8th nerve. Now, this is the point at which maximum people get confused. What do you mean by distal? What do you mean by proximal? So just consider, if this is your CNS, the nerve which is close to CNS, is proximal. Okay, nerve away from CNS. If this is your nerve away from CNS, this is distal nerve. Okay, so when the nerve arises from cochlea, so nerve near the cochlea is distal nerve and not the proximal nerve. Is distal eighth nerve because it is away from the central nervous system. The nerve away from the cochlea is proximal nerve because it is near the central nervous system. So by first E I mean the distal eighth nerve, from second E I mean the proximal eighth nerve, from C I mean same, that is cochlear nucleus, from O I mean olivary nucleus, from L lateral lemniscus, I inferior colliculus, and M and A are not that important wave for us. Important wave for us are till L. Okay, so let's discuss. So this first wave, the formation of the first wave is due to the loss of some of the electrical stimulus from the distal part of eighth nerve. So some of the electrical stimulus get lost from the distal part of eighth nerve, that leads to the formation of the first wave. Wave 2 is formed from the proximal part of the eighth nerve. Wave 2 is formed from the proximal part of eighth nerve. Wave 3 is formed from cochlear nucleus. Wave 3 is formed from cochlear nucleus. Wave 4 from olivary nucleus, opposite side olivary nucleus. And wave 5 is formed from lateral lemniscus. Now you will get my point that in the mnemonic of E. coli, I have told you that you have to remember from L that it is lateral lemniscus and largest. By largest I meant that the wave which is largest in the BERA is due to the lateral lemniscus. So the wave which is largest in BERA, it is due to the lateral lemniscus. So very simple to remember what is BERA. First point, what is BERA? So BERA is Brainstem Evoked Response Audiometry. How many waves are formed? 5 to 7 waves are formed. What is the principle? Some of the electrical stimulus are lost. Some of the electrical stimulus or energy is lost, that is picked up in the form of waves. So what does the various waves represent? First wave represent distal portion of the eighth nerve, second wave proximal portion, third wave cochlear nucleus, fourth wave olivary nucleus, and fifth wave, which is the most important and represent the lateral lemniscus, and it is the largest wave. Sixth and seventh wave you can easily answer, it is inferior colliculus, and seventh wave is medial geniculate body. Okay, so this is very simple to answer. If you use this mnemonic, that is double E. coli. Now how does you interpret BERA? Okay, so how does you interpret BERA? Just consider this is your first wave, second wave, third wave, fourth, and this is your fifth. Okay, important for us till that this third, fourth, and fifth. Now consider that your first wave is delayed. But all the other wave are normal. That is latency between them is normal. Okay, only the first wave is delayed. So where does the pathology is present? So you can remember that you know that first wave is from distal portion of cochlear nerve. That means there is some pathology before distal portion of cochlear nerve. So if this is your cochlea, this is your distal part of cochlear nerve, some pathology is present before distal portion of cochlear nerve, that is some pathology is present in inner ear or middle ear. Okay, you can remember this point. So if there is increased latency for wave 1, indicate cochlear pathology. Now suppose another condition. This was the first condition in which wave 1 was delayed. Okay, wave 1 was delayed. Now consider second condition. In second condition, wave 1 is normally present. But the interoral latency between this is increased. Okay, so what does this indicate? There is some pathology in between the distal portion of the cochlear nerve and lateral lemniscus. There is some pathology in between the distal part of cochlear nerve and the lateral lemniscus. Now let's consider one another condition that only wave 1 is present and rest all other waves are absent. Wave 1. So this indicate a retrocochlear pathology. That means something is beyond distal cochlear nerve. That means it is a retrocochlear pathology. If wave 1 is delayed, it indicates cochlear pathology. If only wave 1 is present and all other waves are absent, it indicates some pathology in the retrocochlear region. If wave 1 is present but interoral latency is increased, latency between various waves are increased, that indicates some lesion between the distal cochlear nucleus and the lateral lemniscus. So in one of the clinical condition, this is the most diagnostic test. Now what is that clinical condition? If you know about acoustic neuroma, what is acoustic neuroma? So let's discuss about some basics of acoustic neuroma. If this is your nerve, around your nerve is present your Schwann cells. This is your Schwann cells. If there is uncontrolled growth of this Schwann cell, it leads to a tumor that is known as acoustic neuroma or schwannoma. Acoustic neuroma. Okay, this is known as acoustic neuroma. Most common nerve involved is inferior vestibular nerve. So there is pathology in retrocochlear region. Okay, retrocochlear region, that means the waves will be delayed. The wave 5, especially the wave 5 will be delayed in that region. So suppose this is an individual. He is having tumor in this inferior vestibular nerve and this nerve is absolutely normal. When we will take the BERA of this patient, the normal side will appear like this. That is, this will come at 5 millisecond. Okay, the wave 5 will come at 5 millisecond. Very simple to remember. Fifth nerve, fifth millisecond. Okay, here there is a lesion in the vestibular nerve. So the waves will be delayed. So if in between the two ear, suppose this wave come at 5.2 millisecond. If in between the two ear, the interoral latency, by this I mean between the two ear, latency for fifth nerve is more than, difference between them is 0.2 millisecond. It is diagnostic of acoustic neuroma. Okay, so what are the various ways to interpret BERA? Let's summarize it. First, wave 1 is delayed. Okay, let's write it together. First, wave 1 delayed. If wave 1 is delayed, that means something is present in the cochlea, that is cochlear pathology. Second, if only wave 1 present, that indicates retrocochlear pathology. If interoral latency more than 0.2 millisecond, diagnostic of acoustic neuroma. Okay, so these are the various way for interpretation of BERA. Now what are the various sites at which you will use the BERA, or what are the various diagnostic tests in which you will use BERA? So first, indications for BERA, where do we where you will do BERA. Number 1, it is the best test for diagnosis of hearing in neonates and child. Why it is the best test? Because it is objective test. By objective, I mean that here you do not require response of the child. You do not require the response of the child. Okay. Second, it is best diagnostic test for malingering. Second, it is best test for acoustic neuroma. Next, it is best test to differentiate cochlear and retrocochlear lesion. Okay, so these are the various important points about BERA. Okay, so now what is the drawback of BERA? What is the major drawback of BERA? So the major drawback of BERA is, what is the major drawback of BERA? So what is the drawback of BERA? The major drawback of BERA is when the patient is having severe to profound hearing loss. Then the sound given will not be sufficient to stimulate the auditory pathway, and we will not be able to record BERA. So BERA cannot be used in the patient with a severe to profound hearing loss. Okay, so what we can use in the patients of severe to profound hearing loss? We can use another test, that is auditory steady state response. Okay, auditory steady state response. So what is this auditory steady state response? Let's discuss about a few points of auditory steady state response, that is ASSR. What is auditory steady state response? So in BERA we used to give transient sound in BERA, but in this we will give continuous or steady sound of a frequency, continuous or steady sound of a particular frequency. Okay, when the sound will be given, EEG is recorded. So now we will slowly modulate the sound. And by this sound modulation, there will be change in the EEG. Only if the patient is able to hear the sound. If the patient is able to hear the sound, then the slow modulation in the sound will cause change in the EEG. And this is the principle of auditory steady state response. Okay, so what's the major important advantage of ASSR over BERA is that it can be used in the patient of severe to profound hearing loss. First point, it can be used in the patient of severe to profound hearing loss. And second, very important point, you can see in this diagram, we can find out the hearing threshold. For various frequencies. And hence it is known as multiple auditory steady state response audiometry. Okay, so this is all about BERA and auditory steady state response and auditory pathway. Before concluding, let's discuss one of the point about embryology and BERA. So what happens when the child is developing, auditory pathway will also develop slowly and gradually. auditory pathway will develop slowly and gradually, and with the development there will be development of mainly first, third and fifth wave. When there is development of the child during the gestational age, there will be development of first, third and fifth wave, and this will reach the adult configuration by 18 months. This will reach the adult configuration by 18 months. Okay, so you must remember this point about the auditory pathway, BERA and the auditory steady state response. Okay, so this is about today's session. If you like our work, you can like this video, share this video, subscribe to our channel and stay tuned for many such informative videos. Thank you. See you in the next video.